So the Mirage trial was a single center phase 3 randomized trial comparing CT-guided SBRT, which is a standard of care approach, versus MRI-guided SBRT for prostate cancer. Just in a little bit more detail, SBRT is a type of radiation for prostate cancer where a high dose is delivered per day with extreme accuracy and precision in order to complete the radiation course in just 5 treatments, as opposed to some of the older and longer courses of radiation. Historically, this has been delivered with CT or X-ray guided devices. So that was kind of the standard arm. More recently, we have these MRI guided radiation delivery platforms. And so on the Mirage trial, we wanted to see whether there would be a benefit to the patient by using the MRI-guided device. It's more expensive, it's a little bit slower to do the delivery, but it has numerous theoretical advantages, and we wanted to test that. What did we find? Well, the primary endpoint was physician-scored moderate genitourinary toxicity. What does that mean? That means urinary side effects, like needing to urinate more frequently, needing a medication to control urinary frequency, urgency, or pain with urination. And we found a significant reduction with the use of the MRI-guided device. Specifically, the rate of toxicity reduced from about 43.4% with CT-guided SBRT to 24.4% with MRI-guided SBRT. We also looked at bowel toxicity or gastrointestinal toxicity, which is things like diarrhea, pain in the rectum, urgency to defecate. That was reduced from 10.5% in the CT-guided arm to 0%, no events in the MRI-guided arm. We looked at a number of patient-reported outcomes as well. Kind of what does the patient feel in terms of their symptoms? Are they reporting more urinary toxicity and bowel toxicity? So we give them questionnaires to fill that out. And to boil it down, we did see significant improvements there as well. So the proportion of patients that reported a significant increase in their urinary symptoms dropped from 19.4% to 6.8%. And the proportion of patients that reported some noticeable change in bowel symptoms dropped from 50% to 25%. So the takeaway one sentence summary would be that MRI guidance allowed a significant reduction in patient-reported and physician-scored urinary and bowel toxicity in the context of prostate SBRT. Now, the reason we see this benefit is likely because the MRI-guided device allows a lot more precision. We felt comfortable basically treating a much smaller volume because of the direct guidance that we have with the MRI compared to the standard of care margins that we use when we're treating with CT guidance. Basically, MRI-guided linear accelerators are newly available tools. So historically, there have been a lot of physics-related challenges with combining an MRI with a radiation delivery platform, which is typically a linear accelerator, and that's because of interference. And so this is a newer technology. Essentially, we acquired this device here at UCLA in late 2019, and the trial began in 2020. So right now, there are not as many places that have an MRI-guided linear accelerator. As with all technologies, it takes time to adopt, and hopefully with trials like the Mirage trial showing a true benefit to this approach, we'll see more widespread adoption. So on the one hand, it's a very positive randomized trial, right? And so, we in medicine, we say, the highest level evidence is a randomized trial, and we have that now. However, to be fair, we did look at short-term toxicity, right? So we looked at toxicity that occurs 90 days within a 90-day period after the treatment. And so arguably, someone could say, well, okay, there's less MRI, there's less short-term toxicity with MRI guidance. What about long-term toxicity? Because someone could say, I can get a patient through short-term toxicity, right? And so it will take time to be able to show that. We plan on analyzing our data again at the 2-year mark. So the trial finished all of its patients accruing in about October 2021. So later this year, we will look at 2-year patient-reported outcomes, which is thought to be a kind of a marker for long-term toxicity. And we hope to, see if there's a difference at that point. And I think if we can show a difference in long-term side effects, then that pushes the needle even further in favor of MRI guidance. There obviously with prostate cancer, the cure rate is very, very high, thankfully. And so it takes a long time to be able to show if one treatment is actually superior to the other. And that's not what the trial was designed to do. But I think, long-term outcomes showing that this enhanced precision at least has the same outcome, possibly even better if you're actually able to hit the target more, would also be helpful. So we're also going to look at 5-year outcomes on our trial. However, there are numerous other trials that are being run across the world. Our next trial that we hope to open in this fall will be looking at trying to leverage even some more sophisticated properties of the MRI-guided machine to maybe treat the area that has cancer in the prostate to an even higher dose, and maybe able to drop the dose to the rest of the prostate, which may further reduce toxicity without compromising the effectiveness of the treatment. So that's the next thing we plan on looking at. I would say that the unexpected finding was that we saw this robust benefit in all metrics. So when we designed the trial, when you're designing a trial, you have to pick an outcome, right? And for statistical reasons, you have to pick something that happens frequently enough that you can actually detect a difference. And urinary side effects from radiation are fairly common. And so we thought we could show that. So we designed the trial to show that. We actually didn't think that we would have enough patients to be able to show a difference in bowel toxicity, or a difference in these patient-reported outcomes. It's hard to predict what that would have been. And we did see that. So that is very... it's unexpected. It goes in line with our theory, right, that the better precision would allow, but the effect size was larger than we thought, which I guess in this case is a good thing. I would maybe add one other thing that we plan on looking at in the future, which is of a significant interest to many men with prostate cancer, is actually the sexual side effects. So it's too early to look at that because it's just 3 months after the treatment, and many men are on hormone therapy, which can confound the picture. But we do plan maybe at the 2-year outcome or longer term, seeing if there's a difference in erectile dysfunction, which in theory there may be, again, because of the enhanced precision. So that would be another thing that might also tip the favors in the balance of treating with MRI guidance.